Hi, everybody. Thank you so much for joining us. My name is Sabra Inkner. I'm from AmChip, and we're really excited to have you here for the last of our EHDI Telehealth roundtables. We want to thank CDC for sponsoring these events. And with that, I will turn it over to Carl because we have quite a packed agenda today. Carl, my friend, you are muted. Carl, you're still muted. There you go.
Okay, am I muted now? Sorry about that. So I was saying we're all very excited about the people who have joined us for this session of taking EHDI Telehealth to the next level. We have a great team of 6 presenters lined up who will make brief presentations about both teleaudiology and tele-intervention, some of their experiences, challenges, and successes. And our goal with this session is that by the time we finish, all of you participants will understand, as we do, that telehealth is much more than just a good idea that we can do a proof of concept for and show that it works. It actually is being used, not as broadly as we would like, but it's being used in everyday routine practice. And these 6 presenters will give you examples of how that's happening. The people who will be presenting to us today are listed here. I just noticed I spelled Bill Campbell's name wrong. It has a P in the middle. Sorry, Bill. But they will be each making a brief presentation, and then we'll have a little time for questions and answers after each presentation, and perhaps some more time at the end. This session will be recorded and will be posted on AmChip's website if you'd like to look at it later. So with no further ado, I'm going to stop sharing my screen, and we're going to share Bill's screen, and we'll get started with this. Wait just a second while I call that up, Bill. Okay. Okay, you should be seeing Bill's screen now, and we'll let you take it away, Bill.
Okay, thank you, Carl. Wanted to first just thank everybody for inviting me and having me be part of this. It's wonderful to be a part of it. I'm going to give you just a real quick history of remote infant ABR assessment, which is the area that I have been focused on since before 2008, and then talk a little bit about remote infant ABR assessment programs using telehealth, some of the challenges that you're likely to face, and some of the potential solutions, and just sort of a very brief overview of a readiness plan if this is something that you're planning to implement. The brief history, this does go back to about around 2005, when Mark Crum and some colleagues at the University of North Dakota looked at screening and ABR assessments remotely using telemedicine. That was something that in our area in Canada, in Northern Ontario, we were very interested in, but technology and equipment wasn't up to the task until about 2008, when the NavPro systems finally moved out of a DOS-based system and into a Windows environment. And in 2008, we did start piloting that, looking at setting it up, and then and actually implementing implementing that in our clinic using one hub site, and we had at one point in time 9 spoke sites to assess infants in remote areas, fly-in communities in Northern Ontario. We've come a long way since then. The technology has changed dramatically in both the ability to connect and what we use to connect to systems remotely, and also in terms of the ABR equipment platforms and how we can utilize those, as well as the ability to incorporate other aspects of the test battery beyond just ABR. That includes, in some areas, acoustic emissions and tympanometry and video otoscopy, to name a few. So interest has been growing steadily, as Carl had mentioned. It's not quite widely implemented as we would have hoped, but it is growing, and especially with the recent pandemic, interest has really peaked quite a bit. There are a lot of programs internationally. Certainly there's in Ontario, we have still on a small scale, and in British Columbia and Canada, they use it as part of their province-wide program. And there's several in the US as well, one of the more noteworthy being the University of South Dakota. So it's gaining, gaining popularity, although we're still a little bit behind. So if you could advance my slides, Carl. Thank you. So remote infant ABR assessment can solve a lot of problems for us, or solve a lot of issues for us, mainly in being able to bring the clinician or more efficiently utilize the clinician. We can rather than bringing the clinician to remote areas, we can remotely bring the clinician to those areas. By doing that, we reduce travel costs to families, and that's there are several studies from the US, Canada, and the United Kingdom that do show significantly reduced costs due to travel and childcare, both for parents and for agencies that fund travel. Certainly in Northern Ontario, where we have fly-in communities, we see significant reductions in cost by not having to have people fly in for access to services. We also are showing reduced loss to follow-up. We do find, in our pilot program, and other areas have definitely shown this, that children who refer from a screening, from a whether it's an OAE screening or an ABR screening, you do tend to see increased numbers accessing the actual assessment, and thereby reducing your loss to follow-up. Remote using teleaudiology definitely reduces program costs that you see in terms of clinician travel time and expenses. It's usually not efficient to have a clinician traveling out to some of these remote areas. You're paying for the time in traveling, you're paying for the cost to get to where they need to go. And it's just much more efficient to have a clinician working from their own clinic area, as opposed to having to go somewhere else and repeatedly set up. And the infant ABR is a highly specialized area of practice. There's not a lot of us. And this does really extend the reach of these highly specialized clinicians. It allows them to work beyond the clinic, the immediate clinic area where they would normally see patients. We have seen patient satisfaction, family satisfaction. When we did our pilot in 2008, 2009, our data certainly showed that families were receptive to teleaudiology services. They were grateful to be able to receive them, and a significant number stated that they wouldn't have otherwise accessed EHDI services. And this is being shown in British Columbia, in the UK, and in areas of the US as well, where often in remote communities, people are used to receiving medical care via telemedicine, so it's not a new thing for them to experience. And because they're used to it, they have no problem with accessing services that way, and find that it's a beneficial service for them. We'll take the next slide, please, Carl. Thank you. As I said earlier, COVID has been the impetus to a little bit more programs delving into teleaudiology. But these benefits extend far beyond the pandemic environment, as it were. And so it's kind of my hope that the interest that's been piqued during COVID is gonna keep going on beyond that. As I said, you can extend your reach, you can provide effective, equitable services across all regions and reduce loss to follow-up. And also improving your ability to hit your program goals and targets. For example, I know in Ontario we follow, and most programs do as well, the JCIH targets of screening, assessment, and identification and intervention. And using remote infant assessment does improve your ability to hit those targets, primarily because you're just able to see the children earlier and you don't have to wait on travel. And we'll go next. Yeah. One of the things that I found in working with this, whether it was in our own program or other programs, is that it's pretty easy to just say, okay, I'm gonna take a laptop and I'm gonna send an AVR system out to a remote area and we're gonna train someone and get them started. But that sort of knee-jerk approach is generally not sustainable. And one of the things I've really learned throughout all of this is what you need to do if you want to implement a program that is going to be a sustainable program. The first thing to check off is this, just because you can do it doesn't mean that you necessarily need to do it. So is this a service that is going to work for your area, for your program, for your region? It is critical to take a close look at individual program needs, because every program and region is different and unique. You want to make sure that it's right for your program and for your clinic and your clinicians. You've got to look at how they're going to implement, how they're going to schedule, how the clinicians are going to fit this into their current scheduling, with a number of other tasks. You also, if you're lots of times a program may be implemented out of a single clinic, but it may also be implemented within a larger agency, and it's very important to have that agency support. It's important to understand that whether or not a remote assessment is in line with an agency's mission goals and their vision. So having that support is key to having a successful system. IT support is very, very important. And having an IT department behind your, having your back with all of this is key and very critical. Often IT departments are a little bit resistant to this, and this is one of the challenges we certainly faced. Plugging into an infranet or an infrastructure does have some risks to that infrastructure. And IT people are, as they should be, are very protective of their structure and having any risks. Using a desktop sharing software has the potential of having somebody from outside that spoke site, that agency where you're seeing the baby, be able to access things in beyond just the ABR. And so it's important to have the IT department very comfortable with what you're doing, and willing to back you up and support. And many times you are working across, from one agency to a completely different agency. So you've got two IT departments involved. So it's important to be on top of that. It's important to know that you've got expenditures. You've got to figure out how you're going to be reimbursed for this. You've got to look at who the key staff will be, who will be your clinicians at the what's called the hub site, which is where the clinician will be, and who will be your people at the spoke site, the remote site. And wherever possible, utilizing your existing resources. And now we'll go to the next slide, Carl. In order to have a sustainable program as a component to any EHDI program, you really got to have a clear and effective plan in place right at the beginning. You need to have solid reimbursement solutions in place, and you need to have a program that's flexible enough so that reimbursement can change when there are changes in third-party payer evolutions and solutions. Staff need to feel comfortable with remote ABR, and that's one of the challenges I think that we've faced certainly, and that I've seen other areas face, where there's a little bit, not every clinician and every technician is as comfortable with technology as others might be, and so you've got to overcome that concern, especially on the part of the clinician who's delivering the ABR assessment, to have them understand that the assessment remotely is the same as an assessment in person, but to have them comfortable with that. The staff have to be flexible in order to allow this to work into their scheduling. And that's also a challenge. And then, of course, agency and administrative support needs to be consistent and needs to be written in as part of a program's policy. So, and again, Carl. That's a very brief overview. There is a much more concise presentation on the NCHAM site, I believe, in the learning community. But my email address is there. If people do have questions about implementation, I'd be happy to help, either directly or to direct you to someone who can. So thank you very much for your time, and we'll pass that on.
Thank you very much, Bill. Let me start with just one quick question, then we're going to have to move along. But just an approximate, doesn't have to be exact, how many infant ABRs has your group done over the last year or 2 years or 3 years?
Well, we ran the program through our health unit, the initial pilot program, and we ran that for 2008 to about 2011, and we saw about 129 or 128 babies, which may not seem like much, but given our birth rate in our area, it's actually a fair number, because again, we were only servicing our 7 to 9 remote communities. Now, since then, I've been retired. Well, not quite since then, but I'm now currently retired, and the program has been gone through some changes. One of the big, as I said before, having agency support and ongoing consistent support is important. But having that support be consistent when you move clinics is a challenge as well. So the program in Ontario is currently going on, but it's still in a pilot phase because a lot has changed, mainly our cytomegalovirus monitoring. So,
well, I'd say 119 babies or whatever you said sounds like a lot to me. So, and I'm going to stop sharing Bill's screen, and we're going to go next to Todd Houston from the University of Akron. So Todd, do you want to share your screen and take over?
So thank you, Carl, for allowing me to be a part of this stellar group of individuals. Can everyone hear me okay?
Yes.
Yes, great. So I was asked to sort of look at the current issue of the JEDI, or the Journal of Early Hearing Detection and Intervention monograph, which was just released this week. So I hope that all of you have had a chance to read all of those amazing articles by now. I think it came out yesterday or day before. But I am Todd Houston. I have been at the University of Akron for 11 years on faculty. I'm a full professor there and have been doing telepractice there during that time, and also for the past 8 years at the Akron Children's Hospital with their cochlear implant program. And so, and then before that, I was doing telepractice while on faculty at Utah State University with Carl and others. So just recently, this past fall or so, the idea came along that we would do a monograph, and I have to give special call out to Arlene Stratler-Brown, because about almost 10 years ago, we did another monograph through the Volta Review, where she edited that monograph focused on tele-intervention and telepractice. And so when this opportunity came along, we thought this would be a great opportunity for this issue of the JEDI Journal to do another monograph and focus on this important topic. And so I have to also have a shout out to Lori Nelson at Utah State University and Christy Blazer at Idaho State University, who were also editing as well. And the contributing authors in this monograph, you see quite a number of people and programs. And I have to say that the tele-intervention learning community also very much supported this monograph and many of the articles that were published, the research. And so my hat's off to all of them for the hard work that they put in, not only collecting data, but also writing these articles and getting this out to the public, basically, and having this be a very important document, so to speak, that can help guide that next level in terms of tele-intervention. And I also have to say that many of these people contributed to that monograph 10 years ago. And so it's to say that most of these people were doing tele-intervention way before COVID, way before it was cool. And so we've been doing it for a long time. And so this monograph also reflects some real expertise that has been there for a number of years. And so what have we found in this monograph, just to hit a few of the key points? Well, if you leave this presentation and this panel discussion with no other information, I want you to leave with just one thing. One point, and that's this first one, that early intervention services can be delivered both effectively and efficiently to young children with hearing loss and their families via tele-intervention. We know that to be true. We have the research to show the outcomes. And what we are also seeing, and what we saw, of course, with COVID, is that everyone had to do some type of distance education or tele-intervention or telepractice in order to provide services. But, and what we saw with the pandemic was sort of like Bill was mentioning as well, is that it did give this big boost, so to speak, to telehealth and telepractice. And then we're starting to see sort of a swing back. And some people are seeing this as, oh, well, we only had to do that because of the pandemic and sort of trying to leave it behind. That is not the way to think about tele-intervention or telehealth or telepractice. It is here to stay, and it's going to become even more vital as we go forward. And so the other thing that we also saw with the pandemic is that a lot of people had to do this kind of service delivery with little or no training. They had to sort of jump into it literally from going home on a Friday and coming back in to work on Monday saying, you know, everything you were doing last week, we can't do that anymore. You have to do it online now. And so we have to understand that a lot of people had some bad experiences because of that. But that shouldn't reflect negatively on the actual service delivery itself, because we know it can work. What else have we learned in the monograph? Well, in one study, we saw that 96% of parents were also very satisfied with their teleintervention services, and 90% would recommend teleintervention services to other families. And I certainly have seen that as well in my practice. Well, parents love the convenience, especially if you are connecting to their home and doing that early intervention in the home. They love the convenience of being able to use the materials that they have, use the toys that their children like and enjoy, and not having to travel. And when you have families that live in more rural areas, this is a godsend because they may not have access to really important services. But I also have to say, of course, rural families need to get great services, and teleintervention may be the way to do that. But there are also families that live maybe right down the street from the hospital or the center or the school that where you work. And telepractice or teleintervention may still be the best way to serve that family. If there's transportation issues, if the child is medically fragile, if there are other siblings, other children in the family that, to take the child who needs the services, they have to get a babysitter, then that's going to be, not going to be cost effective for that family. So we see all these issues being addressed with teleintervention, and usually parents are quite happy with the model. What else have we found? We also found that professionals with more than 3 months of experience are more comfortable. And of course, the more experience we get doing this, the more comfortable we become. That's a very straightforward kind of finding. But one of the things that we have to make sure professionals understand and know how to do, and that is parent coaching. And this kind of goes back to some of our training programs at universities to make sure that their grad students or undergrad students get an opportunity to learn how to do parent coaching. But that continues to come up as being a major issue for some professionals in terms of how do you do it? How do you do it the right way? How do you work with this other adult who needs to learn what to do for their child? And we need to focus more energies across the board. And I work at a training institution, so yes, we need to train our graduate students. For me, it's speech pathology and audiology, to understand what parent coaching is and understand that it is a process and there are strategies and ways to do that appropriately. We also know from the monograph that we can do comprehensive communication and developmental assessments through teleintervention. We now have digital copies of tests. We can do it. We can get reliable results doing it through teleintervention. And what you'll hear from my friend and colleague, Alex Mibos, in just a moment, is that teleaudiology is increasing. And we're seeing more and more of the manufacturers, the hearing technology manufacturers, are making their products to be telehealth ready. So they're already building in the capability of remote programming of those devices. And so the manufacturers are already doing this. And then, of course, as I mentioned, we have to do more to train our students in speech language pathology and deaf education, audiology, early childhood education, all of the different deaf education, of course, all of the different disciplines, to make sure they understand early intervention, interprofessional work, and teleintervention. And so if we can do those things well, then we know they're going to be really prepared for the world that they're going to inherit. Because again, this is where it's all going, folks. And so, and just as Bill was getting into some of the areas of planning, those are also detailed in the monograph, in articles there. And Bill had mentioned doing a needs assessment and doing that very carefully and looking at exactly what your program might need. And I love the old quote from, I think it was Benjamin Franklin, who said, you know, if you fail to plan, you're going to plan to fail. And so a lot of programs, like we talked about, had to jump in and do this for COVID, and without any planning. We don't have that crisis upon us right now, hopefully, and hopefully monkeypox won't be as bad, or anything else won't be as bad going forward. And so it is vital that you plan and you really carefully look at who's doing what, that you have the resources in place to have a successful program. And then you also have to learn how to evaluate the program itself. You know, how many patients can you see, or how many families can you work with? How many children? What are the outcomes in terms of communication and development, and for the children themselves that you're seeing, and being able to track that. And so just to wrap up, you know, as I've said, and as Bill said, you know, teleintervention and this idea of using distance technology, it's only going to continue to grow. And we have to do more to make sure that all professionals understand how to meet this increased demand for these services. And so not only the in-service professionals, but at the pre-service level as well. And with that, I will turn it back over to Carl.
Thank you, Todd. That was a great presentation, giving us an idea of what some of the potentials are. We're going to move ahead to the next presentation now and save questions till the end. I am making notes of questions that are coming in through the chat, and we'll get to as many of those as we can. But if you'll put them into the chat, questions you have, then any we don't get to, we'll respond to following this virtual roundtable. So our next presenter is Arlene Stratler-Brown at the University of Colorado. And if you'll share your screen, Arlene, we'll turn it over to you.
I forgot to push those buttons. Let me try that again.
Okay. There we go. You're there. Thanks, Arlene.
Carl, thank you for the invitation. And Chip, folks, thank you for the opportunity to talk about this topic. I've been studying telehealth for a long time, writing about it some too, as you mentioned, Todd. By the way, that was your idea. I just became the editor on your invitation. So you're the brainchild behind that. Interestingly, and I'm not going to talk about this today, but I was involved in a 7-year study at the University of Colorado to look at the child outcomes of telehealth, which showed non-inferiority. Telehealth, in-person outcomes for children were the same. All the measures were child outcomes. That ended in February of 2020. That was convenient because COVID had not yet happened, at least not right here. And in April of the same year, I became the EHDI coordinator for the state of Colorado. So that's what I'm doing now, but telehealth is near and dear to my heart. As Carl said at the introduction, there's not as much utilization of telehealth as there could be. And what I want to do is kind of explore why that might be and what we can do about it. As our project officer for that study on the outcomes of children using telehealth, he said, and this would be back in 2010, 2012, he said, so this is our project officer from NIH. He said, telehealth is here to stay. We need to do something to prepare. So here we are, maybe preparing after the experience we had with COVID. So I'm going to start with just a couple of take-home messages from a 2018 study that was done by Early Intervention in Colorado, the state group, with my colleagues Beth Cole and Catherine Picard. And at that time, pre-COVID, we had 112 providers reporting on our survey and 39 Part C service coordinators. Back then, the positive aspect of telehealth was it addresses provider shortages, inclement weather, when a parent or a provider or a child are sick, but not so sick they can't do a session, reduces the travel burden. There's flexibility in timing. You can join families maybe during some important routines in their schedule where they're having trouble, and that there was more family engagement. But what offset that was an issue that's barely an issue now. It's the second point here, access to sufficient bandwidth. I think we're almost past that. But it was attitudes. The attitudes were, telehealth is not really family friendly and it's impersonal. And basically the providers and Part C service coordinators who responded said, it's just not as good as in person. So then we got this dose of everyone doing it during COVID, but keep in mind, people didn't do it because they wanted to. They did it because they had to. And hence the boomerang effect that we're experiencing now, where people are, yeah, they're doing it, but they want to go back to in person. But let me share this survey, also from the Part C program in Colorado. Right there in the heat of the first year of COVID, they put out a survey, Early Intervention Colorado did. They had 803 providers respond, over 1,000 families responded, and here are the take-home messages from that work. 50% of the families at that and providers at that point in time said they would continue telehealth, or at least do telehealth with in-person. The technology usually worked with some exceptions. It was really overwhelming when parents had their school-age kids at home, or they were working at home, and they're doing telehealth with their birth to 3-year-old. Hopefully we're past that, but one never knows. And this is going to be a theme here for the next few minutes. Providers need more training, specifically, as Todd was saying, how to work with the parents of the child, not just trying to work with an 18-month-old or a 24-month-old one-on-one. Easier said than done, but Todd covered nicely need for training. So I'm going to pull out some of the data from the studies, 2 of the studies in the JEDI monograph. This one is about parent perceptions, one's about provider perceptions. So Lori Nelson from Utah State led the way, and they're all the contributors. This is about parent perceptions. 48 of those parents were receiving services through telehealth, 18 in person. We wanted to know what's parent confidence in understanding their child's language development. What are those perceptions of coaching? What's the parent-professional partnership like? And we asked for some overall recommendations from parents. Todd already shared with you, 96% were highly or mostly satisfied with telehealth. 90% would recommend it. And this is important too. No differences between the parents' perceptions in response to those questions, if the services were delivered in telehealth or in person. So our CU study looked at child outcomes. This study looked at parent perceptions. We keep seeing it's equal, it's similar. So now let's look at the provider perceptions. Again, Lori Nelson led the way. We had 123 providers providing telehealth. 21 providers who responded to the survey were providing services in person. The questions, 2 of the main ones, are what's professionals' confidence providing tele-intervention, telehealth, telepractice services? And then what are professionals' views and recommendations? Well, here's 3 of the results of many more. Provider perceptions of telehealth services were largely favorable. Those who had been doing telehealth for more than 3 months pre-pandemic, so they had chosen to do it They were probably preparing to do it or prepared to do it. Those providers versus the ones with less than 3 months experience because they started during COVID when they had to, the ones with more experience were significantly more confident using coaching practices. And those with more than 3 months experience had more favorable views of telehealth. And I want to say one more thing about the second bullet. I've been a proponent of family-centered intervention my entire career. I'm just sold on its efficacy and its value. I never saw a better opportunity to sell the need to learn about family-centered practices than we did with the opportunity COVID presented us with, where people really had to learn to coach to pretty much carry off an effective session. And many have said it's influenced their in-person sessions as well, because they really learned how to work with families. My last slide, lessons learned, next steps. I put it number one because I think it is number one. Training, mentoring, reflective supervision from others who are comfortable with it is known to be effective. This comes right from one of the articles in the Jetty monograph. Training should include a commitment to the longevity of telehealth that is probably here to stay. But we have to improve provider efficacy and provider confidence. So what happened in March, April of 2020, just do it. It's better than nothing. We don't want to carry that on. We want to plan for it, just like Bill was talking about with teleaudiology. How about the teamwork? How about peer mentoring? It's just something I'm really keen on, and I think that we learn well from each other. We learn by watching what others have done. You can easily just videotape a session, a good session, and let others watch it. That's what I mean by peer mentoring. And specifically, you need to learn how to work with parents, the coaching practices. There are three other things I think are really important as we move forward. We need good messaging so that we have buy-in. We need guidelines on utilization of the, everyone's learning Zoom, but everyone doesn't use Zoom. And what tools might you go and try beyond just getting online? We need to query all the stakeholders, parents, providers, or Part C coordinators, administrators, managers. So let's keep these surveys going so we can understand the changing supports that are needed for success. It's no secret, I'll say in closing, that we don't have enough providers to meet the need of all families in all geographic areas. I think that when families want highly specialized providers, whether it be bimodal, bilingual support for their child, an ASL approach, a listening and spoken language approach, parents deserve specialized, highly specialized providers. And this telehealth provides access. We know we don't have enough teachers these days. We know we don't have enough special ed teachers. We know we don't have enough teachers of the deaf and hard of hearing. We do have expertise that can cross county, school district, and state lines or country lines so that we can help our kids and their families. My email is on the first slide, and I will stop there. Back to you, Carl.
Thank you, Arlene. Great presentation. Please remember to continue putting your questions in the chat, and we'll have some time at the end, I hope, to talk about those questions. If not, we'll be able to respond to you offline, and you can get in touch with presenters at any time. They're all interested in talking more about this. As you can see, they are passionate about it, and there's a lot of work still to be done. Our next presenter is Alex Mibos from the University of Akron. Alex, if you want to share your screen and take it away.
All right, can you hear me okay on my end?
Yep.
All righty. Well, I appreciate those who have spoken before me. It provided a good backdrop for some of the things that I'm going to discuss. But largely, I'm going to shift a little bit away from the kind of idea of standard appointments into what we do on our smartphones on a daily basis. And so, as Todd mentioned, I was invited to help with the monograph in JEDI, and I did a review of eHealth hearing technology platforms, and specifically whether or not they could be catered to pediatric teleaudiology applications. An eHealth platform is essentially an electronic information or communication technology link where you take a patient-owned technology, such as a computer, smartphone, or tablet, and you link that to the clinic-managed technology. And so this provides opportunities for real-time synchronous video conferencing, such as Zoom that we're using right now. It also provides a synchronous exchange of health information, and then of course, online social networking or peer support, group development. But the difference between this and what we're doing in Zoom is that it's highly kind of secured for the purpose of that medical record and information sharing. So during the pandemic, as many people have already mentioned, applications for this came about with large hospital settings integrating something into their electronic medical record system where they could schedule an appointment, pull up a video conference. Here in Northeast Ohio, the Cleveland Clinic was a big proponent of this type of model through their EMR system called Epic. And then other iterations of this exist. But that allowed you to have a one-on-one visit with your primary care physician, family physician, or pediatrician to get up-to-date information on your health. If you couldn't schedule that in-person appointment, perhaps you could go get a blood test, but then you could schedule the appointment to talk with your doctor afterward about the results, rather than having to go in the office due to the pandemic's restrictions. So just like we were all forced to do this in audiology and speech language pathology and other services and education, the manufacturers had already been working on developing these types of platforms for the hearing aid companies and cochlear implant companies themselves. And so here on this slide, I've listed the majority or kind of the major hearing aid companies up on the upper half of the screen. And the three largest companies here in the United States, Med-El, Cochlear, and Advanced Bionics for cochlear implant companies, as these are the names that we often know in audiology who provide the majority of services to children, particularly those younger than 5 years old, so that birth to 3 category. And speaking of all these manufacturers, many had a platform that was already in development for adult populations. But with the pandemic starting, there were many pediatric audiologists considering how could I apply this to, the family that's not going to make it to their next 2-month or 3-month visit, so that I can do some data logging and tracking to see how their particular devices were performing. And so the 6 hearing aid manufacturers that were ready during the pandemic to offer these types of services included the 6 that I've listed here: Resound, Signia, Starkey, which has this Thrive hearing control app, Phonak through the MyPhonak app, and then Oticon and Widex. They had a dedicated remote care app that you could download on an iPhone or an iPad or some Android applications. And then one of the cochlear implant manufacturers just during the last year in 2021 developed a piece of their app called the Nucleus Smart App to develop a aspect of the app that allowed you to check on the device status and check some features of it. But some of these also were limited in that you couldn't do a lot of remote programming or troubleshooting of the devices themselves. But something that Phonak developed in the process of the pandemic was a pediatric specific app called the MyPhonak Junior. And this was likely developed in the process of them being one of the largest market holders for pediatric products in the audiology and hearing aid world. And a study was done prior to the release of this app by Newman and colleagues back in November of 2021. It was published in the Hearing Journal. And what they did is they found some families who had children ages 5 through 17, and they did a repeated measure study looking at 3 different remote visits, looking at simple things such as any questions the family may have had since the initial fit, looking at device functionality, data logging, and how often the children actually wore their hearing aids. And they reported back to the researchers on their experiences, and both parents and audiologists provided some of their insights. Of those that reported, all said that the platform was generally easy to use, it was convenient, they were confident it was going to meet the child's needs, and they were satisfied with the remote support aspect that was offered through the app. And this specific app offered some telehealth video conferencing, as well as some minimal basic programming support if there was a troubleshoot that may have been needed in the hearing aids themselves. And at the end of the study, most also indicated that they were very or extremely likely to use remote services again in the future. And more than 50% of the parents reported they actually preferred a remote support visit over a face-to-face or kind of combination visit. And so with that as a backdrop, my specific article in this month's JEDI release was to review current pediatric tele-audiology hearing technology platforms for young children. And in doing so, I went through all of the Apple App Store apps that were available, the Google Play Store apps that were available, and I wanted to identify those that were advertised from a consumer perspective to have an app or an application that was conducive to the needs of an early intervention application. And so for most of these, I looked for that age range or age rating and looked for anything that either said all ages, everyone, or anything younger than 5 years of age. And so these are 2 examples. The MyPhone Junior app lists the age rating of 4 and older. The Resound Smart 3D app listed that same age as well. And in identifying and scouring the apps that are available, only 4 listed these age ranges, including Phonak, Oticon, Resound, and Widex. And across these particular manufacturers, I noted that the pediatric compatible devices that worked with these systems also provided an app that was free for them to be compatible. And when I wanted to know what was important about the features, the NCHEM Telehealth Teleaudiology Guide provides some important features that you may want to consider when selecting a platform for children. And then an article in the Hearing Tracker website by Coppathorne showed some additional features, such as being able to communicate with the audiologist in real time and provide some feedback, be able to work with other accessories, provide some remote programming, and then do some things even like a feedback measurement over the internet, where it could assess for times when a child's hearing aid may be providing whistling or troubleshooting some programming needs where they needed to turn down the volume or adjust it for better comfort. Now, while some of these features aren't as safe to use from a distance with younger children, birth to 3, because the children themselves have a harder time giving us that verbal or perceptual feedback, having them to support the parents in moments where they can't come in and can provide quite a bit of support in the event of them having that in the moment versus having to wait another 6 months or more to come back in for that troubleshooting, when you lose that opportunity for them to develop language and get exposed to the language in their environments. Using these 12 categories of features, I did a review of the 4 platforms that I noted and found that the vast majority of them had these features built into the apps, with one interesting finding that Phonak and Oticon tend to have more pediatric products, and yet Resound and Widex actually offered slightly more features than these 2 lines. And so my hope is that the manufacturers will take note of these differences and some of these features and try to apply them and appropriately provide them to the families when they're warranted. But another thing to note is this review was completed back in December of 2021. And just like your news app or other apps that you may have on your smartphone, these are always under development and being updated. And so chances are, even before the end of this year, many of these things that are missing may yet be available in either the Phonak or Oticon apps themselves. And so in summary, what I found from this review is that we actually have a lot of platforms that are essentially early intervention ready, including important features for checking in with families of young children, that of data logging and average hours of daily hearing aid use, remote troubleshooting, connecting in real time over video conferencing. And the biggest support is that these were developed, the software, the cloud storage, the privacy and security, all maintained and supported by the manufacturers themselves. So we're not having to look for a third-party option. We can go directly with the software and the technologies that are compatible on both the clinician and patient end. Where we could use some improvement is that not all the features are included in all the platforms, including those that tend to have that higher market for pediatric dispensing. And as of right now, I've talked about hearing aids. Only one cochlear implant company, Cochlear, is offering a remote support through their platform for some information sharing. But there's no cochlear implant or bone-anchored hearing aid implant programming platform just yet. We're still reliant with that population upon sending physical equipment, be it a laptop or other devices, to be able to provide that support at this time. And then one last area of improvement that we can work on is that it's unclear whether any of these platforms are actually meeting the newer recommended telehealth standards for accessibility, which were published earlier this year by the World Health Organization. And so I would recommend to anyone who's considering, if you're an audiologist or work with audiologists and want to bring this into your practice, that you visit NCHAM's website and get more information there. They have a really good guide that can kind of help you get started and see what may be possible in your practice. And so it's exciting to see this area of pediatric teleaudiology evolve. And I thank you for your time and for the invitation to speak.
Thank you, Alex. That was wonderful. We've got about 28 minutes left and 2 presenters, and we'd like to save a little time at the end for questions. I again encourage you to look at the chat. There's some great questions and also some resources being posted in the chat. So thank you, Jessica Messerschmidt, for your great resources there. And we'll turn now to Pam Dawson. And Pam, if you could try and get yours in about 10 or 12 minutes, that would be super.
Thank you, everybody. My name is Pam Dawson, and I'm the director of a small listening and spoken language specialty program in Portland, Maine. And I also have the privilege of being the facilitator of the NCHAM Tele-Intervention Learning Community. And thank you to both AmChip and Carl for asking me to talk about a topic that I'm really passionate about. I'm going to use my brief time with you here today to highlight how our program is using tele-intervention to support both families of children who are deaf or hard of hearing, but also their early intervention providers across northern New England. Then I'm going to even more briefly share with you some of the tele-intervention resources that have been compiled in that recent JEDI article that many have already spoken about. So Hear Me Now's program began exploring tele-intervention about 10 years ago. And then in 2014, 2 of our providers had the privilege of participating in a 6-month comparative study that was conducted by NCHAM, looking at tele-intervention services compared to traditional in-person home visits. There were 48 children and their families, 15 providers, and 5 different early intervention programs that participated in that study. There is a lot of really interesting reading, and I encourage you, even though it's from 2014, to go to the resources section of the Telehealth page on the NCHAM website to read the full article. But what really excited us, or what really caught our interest, was that the analysis of video recordings of tele-interventions sessions versus those that were conducted in person resulted in higher scores for both provider responsiveness and also parent engagement in the home visitors rating scale version 2. And that was highly motivating to us to want to continue to expand our teleintervention, because maximizing parent engagement had long been an identified goal of our practice. So after we participated in that study, we wrote a grant, and we made a concerted effort to reach out to Part C and pediatric audiology practices in New Hampshire and Vermont. And the goal of that outreach was twofold, both to offer teleintervention direct services, but also professional development opportunities to build the capacity of local early intervention providers in those 2 states so that they could better support families who had a desired listening and spoken language outcome. As we collaborated with these different IFSP teams, we learned that we needed to be flexible to meet their needs. So we came up with several different models that we continued to use in both those states. In some cases, the Hear Me Now provider is providing direct service to the parent and child through parent coaching and regularly scheduled teleintervention visits. In other cases, the Hear Me Now provider is providing direct service to the family, and the local provider is there in a supporting role. And that could be anything from what some people would describe as a co-treat model, but it could also be that our provider is joining by teleintervention maybe once or twice a month, and the local provider is carrying through and supporting techniques and strategies that have been discussed in the parent coaching on those off weeks. And then a third way that we are providing supports is just coaching both the local provider and the parent through the session. And oftentimes the local provider will start out more in a supporting role, and then when they feel ready, they move on to take the lead with the family. We've been consistently keeping child outcomes that are determined by the individual IFSP teams, often following along what is required by each individual state, as well as Hear Me Now session notes, which tend to focus on auditory skill development. We're also keeping track of providers, the local providers' knowledge, skills, and comfort level, both in terms of their parent coaching skills and also their comfort in supporting a child with who is deaf or hard of hearing. And we also sort of lifted a pre and post survey from that original study that we participated in about the provider's comfort level with providing services through technology, how they feel when they start, and then how they feel after they've been with it for a while. Family outcomes. So pre-COVID, we had made arrangements. I said that we're very small, and we wanted to, again, videotape the sessions to see if we were able to see over time that there was an increase in parent engagement and involvement. And I had made arrangements with a local university for some raters to do that work with the home visitors rating scale. And unfortunately, that piece sort of all fell apart with COVID, but it is our intention to look at that as well, because that's one of the main reasons that we originally started. And as I said, parent engagement has always been a real passion of ours, and we have been very interested in the perspective of the local providers that we've been working with. And I wanted to just very briefly share with you what a local speech pathologist who worked with a family in New Hampshire that we coached and provided had to say about what she saw with the family engagement through teleintervention. And I apologize, I have not been able to get the captioning working on this video today, and I apologize to anyone whose access is affected by that.
But some people say that telepractice focuses more on parent participation than in-person sessions. What do you think about that?
I think that's true.
How do you think that happens?
Well, I think because you aren't right there, sort of, saying, okay, let's do this. It's more organic. It's what the child goes to, and then you say, oh, okay, so what can you do with that to promote such and such a skill?
Right. And so the provider's not there to say, watch me do it.
Right.
The coach is there to say, can you try? Yeah. Or what can you try?
Right. Or we just talked about, can you do that with that item, with that board, or what he's doing right now?
And what do you think the benefits are to the family in that way when that's done?
I wonder if they feel like they're more in control. It's their program.
Right.
It's what they're doing.
I wonder if it helps them feel like they can do it every day.
On their own.
Yeah.
This was very telling to me, Kathy. So you were setting up a visit and Mom said, oh, we'll be on vacation in Maine then. And we were like, okay, we can do it a different time. And Mom said, no. We're going to be with other family. I want them to see this. I think they'd be very interested. I think they would learn something. I can't go to Maine on vacation with them.
Yeah, that is one of the unique benefits of teletherapy. You can go in their pocket wherever they are.
Right.
So shifting gears a little bit and just wanted to very, very briefly highlight the last article in the JEDI monograph, which is a compilation of tele-intervention resources. And they have been organized from the most broad down to the most specific. So you'll see there's additional information, but then we also organized the resources into tables that have clickable links that will take you to all these different sites that have additional resources. The first is ones that are available through NCHAM and HRSA. And this includes also the NCHAM Tele-Intervention Resource Guide, which is where you'll find both the JEDI article and also the article about that original study that I told you about. Then there are general telehealth resources with a lot of good federal programs and information for people that are beginning to set up a teleintervention program. Telehealth resources that are specific to early intervention. The DEC, FIP, a lot of great information here. And a lot of this came about quickly, but also I find when you click on that in a month from now, there'll be additional information that they have added. These sites are quite dynamic. And then the last is telehealth resources that are again specific to early intervention for children who are deaf or hard of hearing.
Thank you, Pam. There's some great resources there, and I encourage all of you to download that JEDI article, an electronic version, so you can just click on those and go to them. Also, keep putting questions in the chat box, as well as other resources. Our final presenter today is Julie Purdy from Rady Children's Hospital in San Diego, a group that's been doing a lot of teleaudiology work over the last few years. So Julie, we're looking forward to hearing from you. If you can try and finish up by 3:30 or by the bottom of the hour, that would be great.
Yes, I'm going to absolutely try to do that. Here we go. All right. So my name is Julie Purdy, and I am my screen jumped ahead on me. Okay, so my name is Julie Purdy, and I'm going to really maybe shift gears just slightly and talk to you a little bit about what we're doing and how we got to what we're doing. And for some reason, at least on mine, I have a kind of a weird little green box, but I think I'm going to not worry about that because we don't have a lot of time. So that's just an extra for today.
It
Maybe
looks fine here, Julie.
Oh,
We're
well,
not
good. I have a
that.
strange little affect on mine, but it's okay. So I'm going to talk to you, just like I said, a little bit about what we're doing and how we got there. So initially, a little bit before we really got into the pandemic, we had a real goal to move towards telehealth, and we wanted to work really directly with families in their homes. So we were not trying to remote in from one of our sites to another site. We worked with Oticon and did a pilot. That was our first sort of preliminary attempt at this. And rather than having a follow-up visit following a fitting visit, we opted to try to use 3 telehealth visits. In addition, although we always get patient satisfaction data for all of our families, we used a separate questionnaire that looked at both before and after the family's opinions about telehealth. And we looked at hearing history, attitudes, just general comfort with telehealth. And we scheduled the visits this way. We scheduled our first visit for 60 minutes, about 3 weeks post a hearing aid fitting. We reviewed information with the family about the hearing loss, checked if ear molds were fitting, made sure families could do a variety of things that we felt were really important. We asked them if they'd been able to check the, connect the way they were supposed to. We looked at data logging, and then we reprogrammed as necessary. And we found that we were able to do really all of the reprogramming that we would want to do at a visit if they had been in-house. So that was kind of visit 1. When you look at visit 2 and visit 3, they're a little bit repetitious, but we, a couple of weeks later, went ahead and had a 30-minute appointment, and we checked data logging to begin with. So we wanted to see if we were starting to see increased usage with the child's wearing of the hearing aid. We really addressed barriers to, success that the family might have encountered in that time period. We once again reprogrammed as needed. And then we had families complete an age-appropriate questionnaire, which is something we would also have done in the clinic. So realistically, our visits were not significantly different than what we would do. It's just that rather than having a longer visit, we were now dividing things into shorter visits, but more frequent visits. And then our final visit was 30 minutes. Again, it was another 2 weeks later. And we checked the data logging. We wanted to be sure that we were really having success, made sure families were able to access Bluetooth, some of the features that we would hope that they could access. We looked at any barriers, we reprogrammed as needed, and we had a little bit more of a counseling visit towards the end. So this particular program worked well. We were able to get information from our survey, and the family's attitudes, and I'm not going to go into all of this, this is available elsewhere, but we really found the families, of course, liked the fact that they had a choice and accessibility. But one of the things that really surprised us as a theme in the parents' conference was the theme that the parents really felt that this actually allowed them to be more confident and to gain better competency. And they reported that that was because they felt it was a much less stressful environment than the environment that they had when they came into our clinic. We didn't think we had a stressful clinic environment, but apparently we do. And they really felt that there was a little bit more of this sort of low-key communication. It actually improved the relationship between the audiologist and the parent because they were in their own home. They could show the audiologist different things that were going on actually in the home. So we were really pleased with the data that we got back from our families. So consequently, we have incorporated telehealth in this way with all of the hearing aid manufacturers with whom we work. Very similar program, handling things just the same way I just talked to you about. What we did learn is that it was really, really important that at the fitting, families were able to get into MyChart, which was part of the system that we require to check families in and to initiate a visit. We also learned that families must have the manufacturer app downloaded at that visit because otherwise they would say that they would and we would not be successful and the visit was a waste. And that created a frustration that then made it much more difficult to get the family to engage in a second telehealth appointment. We needed to be sure that the hearing aids were paired and connected and really able to do what we needed to do before we moved into telehealth. And then the last thing that we learned is it's probably not an all or nothing. It's not an all in person or an all remote. We can have a family maybe come in, have one telehealth appointment, and then maybe the family wants to come in, or they want to come in for that first check, but then after that we can use telehealth. So we're starting to be a lot more flexible. And each time we see a family, we ask them, would you prefer that visit to be a telehealth appointment, or would you prefer your next visit to be an in-person appointment? And then we flex based on what the family is feeling, provided we can get them to at least try. And most of our families are very willing to try, and we've been pretty happy with it. So we also use telehealth for both our cochlear implants and also our BAHA patients, and we use that through Cochlear, as has been spoken there, the one manufacturer that allows us some options. And we really do 3 different things. The first thing that we use is remote check, and you see a remote check screen here. We send a family a notification saying that we would like them to complete remote check, and we can ask them to complete a variety of different things. We can ask them to take pictures, we can check impedances, we can check data logging, we can have families answer questions, we can do speech and noise testing. So we tell the family, or we assign the modules to the family based on the age of the child and what we would like to get from the child. We get this information back, and then we are able to look at it, and we have a half an hour appointment with the family and kind of talk about the results and make a decision about what needs to happen next. We have integrated it into really all of our visits. We do the first one right after activation, and then anytime a family is going to come in for programming. The other option that we have, and we were really lucky because we were part of the controlled market release, so we have been using this very successfully for both cochlear implants as well as our bone conduction patients, and that's something called Remote Assist. And Remote Assist allows the family to be programmed, and we are able to do quite a lot of things through our software that we already have on our computers and using the family's phone or smart tablet. And once again, you're going to see the lessons that we've learned on this are very repetitious to what we learned on hearing aids, is that we really need families enrolled at the time they're in our office. We need to make sure they know how to get on while they're in our office. For the cochlear implant portion, we don't have access to program everything that we normally would want to, but interestingly enough, we are able to do most of the things that we would like to do, but we do also need to assign remote assist because remote check, because we want to get data logging still, and that's not available through this particular module. We do the same thing for our bone conduction hearing aids. This has been even more successful because the audiologists feel they can program everything that they normally would be able to program. They're able to do all the things that they would do if the family were in the office. And so we are almost exclusively using this for the families who have devices that will work, and not having them come into the office. This has really been great. One thing, again, of course, is that we need to enroll them. It's probably even more important because many of them are not enrolled in My Cochlear, so we need to be sure that they have access, but provided they have access, we've been really, really successful with this particular piece. And then the last thing we do with cochlear implants, and we've done this for quite a while now, is we have tablets that we will mail to a family. It's really simple to do. We can mail wireless pods in a tablet, and we've worked with our HR team, sorry, that's not HR, IT team, to ensure that we are doing what is required to meet HIPAA standard, and we are able to do that. So we can mail a tablet to a family, set up a programming visit, program the family, and then the family returns the tablet to us, and all data has been wiped from that tablet. So we're able to ensure that we're meeting all of the many requirements that we have. I know I'm speaking rather quickly, but I want to try to get through, because this particular last thing that I wanted to talk about is one that we really are super thrilled about. We were given 10 very inexpensive video otoscopes, and we decided to use those for a pilot, and we sent them out to different families. And what we found—
This one on mute.
Oh, I went on mute?
No,
There,
you're
no,
fine. Carl, I
it's
think
okay.
that was on you.
Yeah.
Oh, okay. I don't think I'm on mute, but okay.
Oh, you're fine.
Okay. So we sent the manufacturer generated instructions, and what we found is only 4 out of our 10 families were able to give us good images. So we modified our instructions and found that an additional 4 were able to do what we needed, and 1 just refused to send us pictures. So that's part of the deal also. And we asked families to rate how they felt about the use of the video otoscope and the images, and those were the questions. But what we found is that 100% said it was mostly or very true, that downloading the app was not difficult, that using the otoscope was easy, that transferring the images were easy, and that they liked the images and they liked the information. And 78% said it was very true that they would use the video otoscope again. So why would that matter? Well, I think it matters for this next thing. We now are working collaboratively with pediatricians in our ENT group for families that we're all following that have these sort of constant ear-based issues. And we're collaborating to have one otoscope go to those families, and then those images can be viewed by the pediatricians, the ENT, and us. And we can together in our MyChart app, our Epic app, make determinations about who needs to see the family first. So rather than having families bounce from person to person to person to person, we can make very specific instructions to them about where we think they need to go next. So we know that we had to create some documentation in order to do this, and we have that, and that documentation goes to the pediatricians and the ENTs. They are really very capable of them providing that information to their families, and then the families have information that they can use when they get home. So we are really excited about this particular program because we think this will cut down on a lot of that sort of repetitious type visit where the family is told, come back and see us when the ears are clear, and they see the pediatrician and then they see the ENT, and by the time they see us, the ears aren't clear. So we're pretty excited about this particular one. Well, we're excited about them all, but really we're excited about this one too. Now that should get me to questions, and I am, I think, pretty on time.
You are really on time. Thank you, Julie, for a great presentation. Well, it's been an information-packed 90 minutes. We appreciate you're all taking time. There were 120 people online at one point. So you're the people who will be expanding and further developing telehealth services. So thank you for coming. Most of the emails of the presenters have been posted in chat. If you have ongoing questions, I'm sure that any of them would be more than happy to respond to you. We need to keep the conversation going and continue to find new ways of providing even better services using the telehealth model. So thanks for coming, and we're going to sign off now. And with, again, a particular note of appreciation to Amy Sue Guerin, who stepped in to provide interpreting, and to our presenters who did a great job of summarizing a lot of information in a very short amount of time.